Good afternoon, everybody, and thank you so much for joining us in this lecture. My name is Ashraf. I'm one of the cardiologists at Children's National Heart Institute, which is part of the Children's National Health System. I am one of the three preventive cardiologists. My colleagues are Sarah Klaas and Michelle Mayetas Snyder. Today, we will be discussing hyperlipidemia in children and the lipids to screen or not to screen. Feel free to ask me any questions throughout the presentation. The more that you ask, the better that the lecture will go, and you can send those along. I have no disclosures, except I really enjoy telling you the story of the guidelines and how they came along. So on November 14, 2011, and during the American Heart Association meeting, the guidelines were released. 44-page summary report. And if you did what I did that day and did a Google search, you would have found some of these descriptions of these guidelines. Rational, temptation to use medications will be too high, absence of evidence supporting the intervention, and who needs a blood test to tell an obese child that he needs to lose weight. The controversy continued. In JAMA, there was a paper that was arguing against using the universal screening. By the way, this is one line out of the 44-page summary report that got the most of the heat. And in trying to defend this, two of the authors who wrote the guidelines argued for the universal screening. But if you read carefully into the paper, you would realize that one of them actually supported the guidelines, the other did not. And the main authors of the guidelines wrote another paper describing how the guidelines were developed. So in today's session, about 1 hour, I plan to explain to you why the guidelines came up with the universal screening and when to screen those kids. On a happy note, and once controversy occurs in medicine, there will be more papers, and that's exactly what happened with the lipid guidelines in pediatrics. There were many, many papers that were released after 2011, and the conclusion of many of these papers were actually in support of what the guidelines had suggested. By the end of this hour, I hope to discuss when to screen a child for the presence of hyperlipidemia, understand the features of common patterns of hyperlipidemia in children, and identify the lifestyle modification that need to be used to manage children with hyperlipidemia. And finally, appreciate when to refer a child with hyperlipidemia to a preventive cardiologist or to a lipidologist. In adults, atherosclerosis has been shown to increase the risk for cardiovascular disease. In pediatrics, we don't have long-term follow-up study in which we assess children's lipid levels and follow them for 40 or 50 years. Such a study will be very costly and does not exist. But we do have suggestions that hyperlipidemia in children can be associated with cardiovascular illnesses. For example, the homozygous familial hypercholesterolemia kids, a condition that occurs in 1 out of 1 million children, can present with cardiovascular events in childhood. We also know that there are subclinical findings of atherosclerosis that we can detect in children as well. Under good conditions, when an injury happens to the endothelium, the body will be able to heal it completely. Now, when you have evidence of metabolic problems, hypertension, smoking, obesity, inflammation, after an injury occurs, the cholesterol will dislodge in these blood vessels and forming the foam, which end up causing the cardiovascular event. So it's not just the cholesterol profile that's important, but it's also all the other conditions that we have along. This is a nice paper that came out from Johns Hopkins University, and Dr. Clark, as a graduation gift to her students, medical students. She got their blood draw done. And then as a mentor, she continued to follow them up throughout their career. And what she had found is that those who had high cholesterol as they graduate medical school had the highest incidence of cardiovascular events during their 4-year career. We also have learned that some mutations can cause a much lower LDL cholesterol in our body. Specifically, some mutations can affect this gene, PCSK9, and it can increase the expression of the LDL receptors on the liver, thus reducing the amount of circulating LDL levels. Some of these mutations can lower the LDL receptor by 28%. But when you look at those patients, you will find that their incidence of cardiovascular disease has not only dropped by 28%, but it actually dropped by more than 80%. And one argues that the lower the LDL, the better it will be. Now, what we have also learned is that, yes, you can start a child or an adult on a lipid-lowering agent, and you might be able to reduce the LDL cholesterol burden. But what we have learned is that for the same amount of LDL cholesterol reduction, if you were the one lucky enough to have the gene mutation, your reduction improvement in cardiovascular event is far more, it's up to 0.4, it's far more than what you will be able to achieve with starting a lipid-lowering agent. The biggest difference is the mean age. When you have a genetic mutation, you had lived throughout your life from the time of conception, moving on, with a very low LDL cholesterol burden. On the other hand, the mean age for starting a statin is around 40 years of age. And as such, most of the kids and young adults would have been exposed to the high level of LDL for a longer period of time. So what I'm trying to show you with this genetic mutation is that it's not only the lower the LDL, the better, but actually the earlier that you take care of the hypercholesterolemia, the better. There are many conditions that can lead to adult-onset cardiovascular disease. Hyperlipidemia is one of them. Hypertension, obesity, diabetes and insulin resistance, smoking, physical inactivity are all other risk factors. I'm sure you have seen similar tables. These are the normal values. And in pediatrics, we really are looking at the 75th percentile for our values to be the normal values. Anything above the 95th percentile is what we will consider abnormal that will need further intervention. So who should be screened? In the selective screening model, you screen those who had a family history of familial hypercholesterolemia, diabetes, kids with chronic kidney disease or underwent heart transplantation, those with Kawasaki disease, especially if they had an aneurysm, any inflammatory disease, for example, Crohn's disease, childhood cancer survivors, and many of our congenital heart disease patients. Those are the kids that need to be screened. We also would screen children who come from families with premature cardiovascular diseases as well. Bill Neal from West Virginia taught us about the effect of the selective screening. All 5th grade students in his region underwent lipid screening. The first thing that I wanted to come out from this slide is that 71% met the screening guidelines, i.e. the selective screening. So when we go up from selective to universal, we're only talking about 28.6% of the patients in your practice, because most of the others should have been screened by the selective screening. And when you look at the one that did not meet the criteria, you will see that about 10% of them had a high enough LDL cholesterol. And more importantly, when you look at those who would have needed an intervention or under enough risk factors would meet criteria for medications or lipid-lowering agents, you would see that 1/3 of them were not picked up by the selective screening. Why is that important? Well, it's important for that child themselves, but it's also important for the rest of their families. If that child has a hypercholesterolemia suggestive of familial heterozygous one, then most likely he had inherited that gene from one of his parents, if not both, and they need to be screened and evaluated as well. In children, as they go through puberty, there is a normal tendency for the LDL cholesterol to drop. That's because our body needs the cholesterol to form the sex hormones, estrogens and testosterone. And because of that, during this period of time, if you were to do screening during the puberty time, you will be missing some of those kids that had a falsely low numbers. And this is why the guidelines suggested that we do it before and after the puberty, 9 to 11 years of age and 17 to 21 years of age. Now, what do you screen with? Well, what we know about fasting, it can actually affect the total cholesterol with very minimal changes. HDL cholesterol, which is the good cholesterol in our body, is the one that we want to see more of, is not also affected by fasting and is actually measured. Non-HDL is the difference between HDL and the total cholesterol. Most of the labs now give you this number, otherwise you just calculate it yourself. None of these are affected by fasting by much. And what's really nice about that is that you don't need the child to be fasting when you do their universal screening. On the other hand, triglycerides and LDL are affected by fasting. So we have now a measure called non-HDL that doesn't get affected by fasting, which is a good thing. But in previous studies, it was shown to be superior in predicting cardiovascular events in the adults compared to the traditional LDL cholesterol. So not only is it easier to get, but it's actually more predictive. And that's why then universal screening is asking you as a pediatrician to do non-fasting levels, focusing on the non-HDL cholesterol. Feel free if you have any questions to send them along the presentations. If the non-fasting screen was abnormal, then the guidelines suggest repeating a fasting lipid profile within 1 month. I always like to send you guys a table of the guidelines because I think that they are really helpful. And the guidelines are not only focused on the lipids. They talk about high blood pressure, they talk about exercise, nutrition, avoiding smoke exposure, what's important in the family history. So it's worth reading, 44 pages. And the guidelines were meant for you, the practicing pediatricians. They did not develop these guidelines for preventive cardiologists or lipidologists. They actually had you as the main person taking care of those kids. I see this model similar to the ADHD model that the American Academy of Pediatrics came up with to equip pediatricians to take care of those children. We'll go now with some cases, and feel free to ask me questions. Caitlin is a healthy 10-year-old whose parents are very healthy, no history of lipid disorders, and no family history of cardiovascular disease, stroke, or coronary artery disease. So in this child, if you look at table 3.1 in the guidelines, you would see that part of the disciplinary action is to obtain a lipid profile non-fasting. Her total cholesterol was 173 milligram per deciliter, and her good cholesterol HDL was 55 milligram per deciliter. And this gives us a non-HDL of 118, and based on the guidelines, such patients should be congratulated and told to continue with a healthy lifestyle and repeat their profile between the ages of 17 to 21 years of age. This one is a 14-year-old who was referred because of his family history of hypercholesterolemia. His own father died of coronary artery disease in his 60s. The father was diagnosed with cardiovascular disease in his 40s and had multiple bypass surgeries. Based on the guidelines, one would have suggested to obtain a fasting lipid profile in this patient. His total cholesterol was 292 milligram per deciliter, which is way above the normal. The normal is 170 milligram per deciliter. LDL cholesterol is also very high at 240 milligram per deciliter, and you have to worry about it once it hits more than 130. The HDL is not the greatest. It's only at 41 milligram per deciliter, and the triglycerides were normal at 32 milligram per deciliter. Based on the guidelines, this is abnormal, and his non-HDL is also abnormal. And since we had a fasting lipid profile, we can look at the LDL in this particular patient. Figure 9.1 describes to you what to do with a patient who has elevated lipid profile. It specifically divides the patients into those with elevated LDL cholesterol and those with elevated triglycerides. And there are specific therapy for the two different lipid disorders. Generally speaking, first-line therapy is always a therapeutic lifestyle for at least 6 months duration. Now, you always have to exclude secondary dyslipidemia causes. Drug therapy, I see many kids with HIV who are receiving anti-HIV therapy, and they can cause hyperlipidemia. Children with nephrotic syndrome can present with hyperlipidemia as well. Thyroid dysfunction can also present with hyperlipidemia. So you have to make sure that you are assessing the patient for any other underlying disorder before we label it as genetic hyperlipidemia. And we also want to go back and assess the patient's risk factors. You know, what's their body mass index, what's their blood pressure, and how is their HDL doing. And obviously, children with type 1 or type 2 diabetes, we consider them on the highest risk for cardiovascular disease in the future. Kawasaki disease with aneurysms are also in the high-risk group. So in the target LDL recommendations, we want to improve the child's, as a matter of fact, the whole family's diet habits. And that includes limiting sugar-sweetened beverages, as a matter of fact, avoiding it if possible. And then back in the days, the focus was mainly on the fat, and what we have learned with time is that we really need to upgrade everything, fat, carbohydrate, and protein. The more fibers that we have, the better. We need to be careful with the trans fat, basically avoid this as much as you can. All of these tables are available for you in the guidelines, and we plan to send them to you after the presentation so that you can have them for your reference. It's always a good idea to meet with a dietitian. I know some families tell me that it's much easier for them to come to see the cardiologist than to see a registered dietitian. But we have learned that if you meet with a dietitian 2 to 3 times consecutively, the chances of compliance improves with time. Planet stanols is something that some had advocated for, 2 grams per day, and they are added to different food ingredients, including chocolate chip cookies. Again, it's the heart health and nutrition that we are advocating for. We want to improve our exercise capacity. We want to also learn how to be stress resilient and absolutely avoid smoke and smoke exposure. This is the Harvard plate, and the things that I would like to highlight here are that we do advocate for good healthy oils, for example, olive oil for salad dressings or for cooking. We also want to have more green, more colorful plates, so vegetables are also encouraged. Please remember that potatoes in any form doesn't count as the vegetable of the day. Whole fruits is highly recommended. I tell the kids when I see them that, I dare you eat more than 2 oranges at one time. But if you're going to drink a cup of orange, you might have to squeeze 6 of them. It's the fibers in the oranges that will make us healthy, and we advocate for that. The 2 proteins that we love are chicken and fish. Whole grain products are highly encouraged. And please remember that you need to stay very active and drink plenty of water. More examples for you for some of the good, healthy oils. Please, I really want to highlight this. Absolutely no sugar-sweetened beverages if you can help it, and improve the fruits and vegetable servings per day. This is what, unfortunately, most of our kids are eating. So please minimize as much as you can these items. Now, is it safe to reduce the amount of fat that children are taking? I get this question often when I give this presentation. And back in 2007, there was a paper that looked at reducing the amount of fat that children eat. And starting at 7 months of age, there was this trial, randomized trial of kids, of infants. The first group received frequent counseling and reduction in the total amount of fat that they were allowed to eat. And they were followed up until 14 years of age. The big question is, would you affect the development of those children if you remit their fat? And this trial suggested that there was absolutely no difference in growth development of those kids who were subjected to the lower fat intake. On a happy note, they had a better LDL cholesterol than the control group. The American Academy of Pediatrics now had reduced the age at which one can switch to lower fat. It used to be 2 years, and now it's down to 12 months for those with risk factors. So it is safe, and it is something that we should be encouraging. More examples of the healthy oil. Families ask me, do we need fish oil? Well, if you eat fish twice a week, you don't need a fish oil. Unhealthy fats, where you really need to put a no-no as much as you can for all of this in this slide. And when it comes to the carbohydrate, we want to minimize the simple carbohydrate. These are the ones that are fast to be absorbed, quicker in making you feel hungry, with a complex one that will take longer time to eat and make you feel full for a longer period of time. As far as activity goes, the magic number is 300 minutes per week. The child and the family can divide that in any shape or form they like. Now, that does not include the gym class at school. It's any exercise that they do before and after school with 30 to 60 minutes breaks. And I always get the kids really annoyed when I mention that they need to get rid of the TV from their bedrooms. But you really want to advocate for more activity, more physical activity by the child and their family as well. Of course, drop that donut and start walking. Minimize, just like the American Academy of Pediatrics advocate minimizing screen time to 2 hours per day. I would also include educational time as part of the 2 hours per day. Replace that with physical activity. Get sweaty, get exhausted when you are active, because when you do that, you will be able to improve your waist circumference, blood pressure, triglyceride, HDL, as well as insulin sensitivity. So going back to our patient, 6 months of therapeutic lifestyle was suggested, and this is what we end up with. We end up with a total cholesterol of 300 milligram per deciliter, a very high LDL at 226 milligram per deciliter. He did improve his HDL up to 65 milligram per deciliter. Triglycerides were still normal. Remember, this is a patient whose father started having coronary artery disease in his 40s and died in his 60s. So this is a patient that, you try therapeutic lifestyle modification 6 months to 12 months, and if you continue to have such high numbers, then the guidelines would suggest that you repeat the profile, and depending on the risk factors, the child might require lipid-lowering agents. Generally speaking, once you hit more than 190, that's an indication to start lipid-lowering therapy. I know some pediatricians are very confident in starting lipid-lowering agents, and some would rather have me or one of my colleagues in Preventive Cardiology do it. It's up to you. The guidelines do have specific descriptions on how to start the therapy. Back in the days, it was vague to which was the first-line therapy. Now it's clear it is the statins. They have anti-inflammatory effect in addition to their effect on the cholesterol burden. If you have a child with diabetes, for example, you're going to be targeting an LDL of more than 130 because those are very high-risk patients. So in our patient, this is where we were going. We were going to start the statin therapy. The guidelines have tons of tables for you. They talk about why to start pharmacological treatment on those patients. It gives you all the medications that are available, and their profile, safety profile, and some of the clinical trials that were done in children, and how do you do it, i.e., how often do you check labs, what labs do you check, how often do you have to see the patient, and how often do you monitor their profile. All of this is described on tables 9.1 to 9.12. Personally, I don't have any specific statin that I advocate for. As I said before in my disclosures, I don't have any association with any of the lipid pharmacology industry. That being said, you have to weigh in family factors. Some of the old version statins have much lower copay or cost much less than the newer generation statins. So depending on the family and their finances, you might have to end up using an older generation rather than a newer generation. If any of you have any specific questions on starting medications, I'm more than happy to answer these questions during this presentation. Moving along to a 40-year-old who comes from what the family described as a heart-healthy family. They underwent a universal screening by their pediatrician, and the total cholesterol was 197 milligram per deciliter. The profile or the non-fasting profile was repeated 2 weeks later, and the total cholesterol was 212 milligram per deciliter. Mom contacted us via email. We have an email, preventive@childrensnational.org, and this is some of the things that she mentioned in the email. They are vegetarian, they eat very healthy. She put down some specific examples of what they eat, and they are really concerned about her daughter's cholesterol. And when we checked this patient's profile, her HDL was actually 85 milligram per deciliter, and that's really amazing. That is the reason why her total cholesterol is elevated. She has a very good, healthy type of cholesterol, and if you look at her non-HDL, it's normal at 112 milligram per deciliter. On the repeat profile, the non-HDL was also 118 milligram per deciliter. This is the type of family that you just want to congratulate and encourage them to continue with their healthy lifestyle. Those patients do not need referral to cardiology. I do get an email maybe once every 2 to 3 weeks with a similar profile asking if those patients need to be seen in cardiologist. And the answer is no. Those kids are healthy and they should be encouraged to continue with their healthy lifestyle. Moving along to case number 4, a 14 and 11-year-old referred for hyperlipidemia. In this patient, her total cholesterol is 170. Triglycerides were as high as 615 milligram per deciliter. And whenever you have such a high number of triglycerides, the body will reduce the amount of HDL. There is a mechanism of action for this, and the HDL gets affected. Now, once you have a triglyceride more than 400 milligram per deciliter, most labs will not calculate the LDL for you. So this is an effect of having such a high triglycerides. You don't see an LDL value. We really want to spend some time here on explaining some of the issues that came up with the guidelines. Why do we make a big deal about overweight children? Why are we concerned about those kids? And let's take an example of 2 children. One of them is thin, have a body mass index of 22, and one of them have a body mass index of, let's say, 26. Both of them have an LDL cholesterol measured by the labs at 135 milligram per deciliter. What you don't see when you check the regular typical cholesterol profile, total LDL, HDL, and triglycerides, what you don't see is what type of LDL particles are you dealing with. And based on previous presentations, I know many pediatricians told me that this is taking them back into biochemistry. So I would really like to spend some time here. LDL cholesterol, when you look at it under the microscope, it's not the same. Not every single particle is the same. Some of them are smaller, some of them are larger. Now, one thing that they have in common is that each one of them carries with it only one protein. That apolipoprotein is the reason why LDL cholesterol binds to the endothelium of the coronary artery and causes the heart attack. This is the reason why they are what we call atherogenic, that single protein. Each of these molecules, each of these particles, irrespective of its size, carries with it only one apolipoprotein. On the other hand, the amount of cholesterol that each particle carries with it varies. The large particles carry tons of cholesterol. So when you look at this slide, although those two children have a similar total LDL cholesterol, 135 milligram per deciliter, the burden that an overweight child, a diabetic child, has is much more because they have much smaller sized particles. They have way more particles carrying proteins that can dislodge in the coronary arteries and cause the heart attack. So the guidelines is trying to address the issue of obesity because those kids are at a much higher risk for developing heart disease in the future by the type of LDL cholesterol that they have. So in a thin child, you will see larger LDL particles, i.e. more cholesterol per particle, and at the end of the day, less particles circulating in their body. On the other hand, obese kids have much smaller LDL particles, i.e. less cholesterol packed in each particle, which will end up having way more LDL particles circulating in the body, i.e. can dislodge and cause coronary arteries. Please let me know if you have any questions about this particular concept of LDL cholesterol and obesity. Again, the first-line therapy is always therapeutic lifestyle modification. This is the patients that we want to highlight the importance of low simple carbohydrate and more complex carbohydrate in their diet. In the extreme version of lipoprotein lipase deficiency, fat restriction might be necessary. Of course, behavioral modification and support by the family is highly needed. This 23-month-old girl was referred to us by a dermatologist, and I would like you to look at the cutaneous rash that she has. This is in front of her knee. This is what we saw on her elbows. And this is down at the ankle. Now this patient was followed by the pediatrician for a while and eventually was referred to the dermatologist, and a cholesterol profile was obtained. Her total cholesterol was as high as 832 milligram per deciliter, and most of it was LDL cholesterol. This is an interesting patient who comes to us from Thailand. Initially, we thought that we are going to be dealing with homozygous hypercholesterolemia, but surprisingly, she responded very well to therapy. Of course, we had to ask all of our friends around to find out what's the best approach to this patient, and she ended up being started on a very small dose of atorvastatin, and she had a dramatic response in her cholesterol profile within no time. And I just want to go through the slides and show you the follow-up pictures on that xanthomas that she had presented with early on. This is at the first follow-up appointment. They are slightly shrinking in size, but you can still see the demarcations. A few months later, now this is almost a year later, and now we are seeing just the discoloration of the skin. The lesions are almost healing. I mean, you can still see them. And this is her most recent follow-up appointment. I hope that I'm able to convince you that the xanthomas are gone at this point. Her profile is normal, what I would call it a normal profile, and she's doing very well. She's doing at this point very well. So please, if you see such a lesion on the skin, please remember xanthomas and the need to check a cholesterol profile. So in summary, lipid disorders in your practice, you will see 1 in 500 children with familial heterozygous hypercholesterolemia. You might say that that's not that many kids in your practice. But what you have in your practice is the overweight children. And what we know about overweight children is that 40 to 50% of them will have some sort of lipid disorder. the Center for Disease Control and Prevention estimated that 20% of children 12 to 19 years of age have abnormal lipids. And if you look at the obese kids, we're talking about 40 to 50% of them have lipid disorders. So this is something that I'm sure you have dealt with, I'm sure you will deal with, and you have to really pay close attention to. Going back to the guidelines, one of the questions that was raised, could the new guidelines lead to more statin therapy? Is this something that will happen in the future? And Dr. Brian McRandle from Toronto Children did a study that was published in 2013 using public data on children 12 to 17 years of age who had non-fasting and fasting lipid profile. They also had information about their blood pressure, smoke exposure, and body mass index. And what the authors did is they applied the NHLBI, which is the National Heart, Lung, Blood Institute, guidelines to see how many of those kids would require an intervention. There were more than 4,000 participants who had a non-fasting profile. And if you looked at the guidelines, you would see that again, I just want to go back to the guidelines. The guidelines cut point was a non-HDL of more than 145 milligram per deciliter. And if you were to apply the guidelines, you will see that 25% of the sample would have been referred for a fasting lipid profile. So the majority of the patients had an appropriate non-HDL, but only 25% would have required further assessment with a fasting lipid profile. Now, the number of participants who had a fasting lipid profile was lower, was around 3,300 children. The cut point for LDL cholesterol, which is only to be measured during the fasting state at 130 milligram per deciliter. Applying the cut point, you will find that 6.5% would need more intervention or more assessment. And this is really a nice description of what will actually happen. So, as I said before, once you hit an LDL cholesterol of more than 190, almost all of us agree that those patients need a lipid-lowering agent. And here we're talking about 0.4% of the population. This number is very similar to a previous study by Dr. Brian McRandle that looked at 1999 till 2005 age distribution, and that paper was published before the release of the guidelines. So this number is very, very similar to what we have expected before the release of the guidelines. Again, if you had diabetes, then we are talking about a much lower threshold or target to start lipid-lowering agents. Now, why bother about therapeutic lifestyle? Why is therapeutic lifestyle important? And this comes from the Cardia study. In the Cardia study, what they did is they assessed the health lifestyle factors at zero or at the time of enrollment in the study, 7 years later, and 20 years later. The 5 factors that they looked into: number 1, having a body mass index less than 25. This is an adult paper, by the way. So body mass index less than 25, no or moderate alcohol consumption, a higher healthy diet score, a higher physical activity score, and no smoking. So these are the 5 factors that will constitute a healthy lifestyle. Now, not so surprisingly, if you had all the 5 factors, then your chances of having a lower profile is, as you get older, is going to be high. It's up to 61%. Remember that these factors doesn't engage genetics, family history, etc. So there are many other factors that we are yet to understand in forming cardiovascular disease. So it's doesn't predict 100%, it predicts up to 61%. On the other hand, if you start with bad, healthy lifestyle, then your chances of having a low cardiovascular risk profile in the future is going to be very minimal. Now let's look at your role as a pediatrician and what can you do to improve this. Now, the one child who comes to you who is not eating healthy, not exercising, and continues to do that throughout their life, will obviously have a very low chances of having a good risk profile in the future. And the child who comes to you with a perfect profile, who continues to do very well and exercise and eat healthy throughout their life, will have a very good chance of having a low risk for cardiovascular disease in the future. Now, if you are able to affect a change that is done yearly or later in life, you will be able to improve their profile. But the best part is here. As a pediatrician, if you are able to affect the behavior of the family and improve their lifestyle, and they continue to do that, their profile become as good as the ones who came to you with a perfect profile. So as pediatricians, as preventive cardiologists, we need to improve the diet and the well-being of our children and empower them to exercise more, have good food habits and choices. Stephen Daniels was the chairman of the group that wrote the guidelines, and I would agree with him that it is our job, parents and pediatricians, to deliver children with the least risk as they go into adulthood. Universal screening in children, the recommendations are you check the profile between 9 to 11 years of age. If their non-HDL is less than 120, you congratulate that family and ask them to have another profile 17 to 21 years of age. If the non-HDL is high above 145, then the recommendation is to repeat fasting lipid profile within 3 months, and once you get that profile, then you do the management as outlined previously. At Children's National Heart Institute, we are more than happy to help manage those patients with you. If their total cholesterol is more than 200 milligram per deciliter, LDL more than 130 milligram per deciliter, triglycerides 250 milligram per deciliter, or if the ratio between triglycerides and HDL is more than 2.5, or if their non-HDL is more than 145 milligram per deciliter. I know practices varies. Some pediatricians are confident and comfortable taking care of those patients by themselves. We encourage you to do so. That was the intention of the guidelines released. If you have any questions, feel free to contact us, and if you want us to manage those patients, we are more than happy to do so. If a child has significant hyperlipidemia, we do ask of you to obtain labs to rule out secondary causes, including thyroid function and assessment, the cardiovascular risk assessment with insulin sensitivity, liver function in case those kids might need lipid-lowering agents, renal function, and specifically looking for nephrotic syndrome, and ensuring that all the resources are available for the families, including weight management programs for those who need it. These are our numbers. Feel free to contact us if you have any questions. This hopefully will be distributed to your offices. We do encourage you, for children who are overweight, to refer them to a weight management program, for example, the Ideal Clinic. Some of you I know have your own weight management program, so feel free to utilize that as well. This is our website, just a picture of the new improved preventive cardiology program. We have resources for you as well as for the parents, and we're more than happy to answer your questions if you have in the future or immediately after this lecture. This presentation that I just gave you, I didn't mention this earlier, I should have disclosed it. We presented this at the Pediatric Academic Society meetings twice. The first year we did it, Dr. Brian McRendell and Ray Allen-Cavey joined us. And in the second year, in 2014 in Vancouver, Dr. Ray Allen-Cavey, myself, Sarah Klaas, and Michelle Maita-Snyder presented the workshop. This is our email, preventive@childrensnational.org, and I'm more than happy to answer any of your questions if you have them today, or if you have any questions in the future, feel free to email me or my colleagues. We're more than happy to answer any of your questions. Thank you so much, and have a great day. If you like to ask a question, you can unmute your phone. I was told that there is a chat feature. I see it up on the top of the screen where you can type in any questions you like. So there is a question. The question is by Dr. Schreier-Smith. What about the screening panels offered by companies like Health Diagnostics in Richmond? So when I visit pediatricians in the local area, I have learned that there is a CLIA-waived blood test that you can do in your office. It's similar to a mini CBC that you can do. And some pediatricians locally, and here I'm referring to Alexandria, Virginia, shared with me that they actually do get reimbursement for some of these testing. I am not familiar with the Health Diagnostics in Richmond. So there is another question here, actually two questions from Monica. Are you going to send the guidelines? So what I would like to send you, the guidelines are 44 pages, and I would recommend that you look at them. But what I did is I copied and pasted all the tables in a short version, and that's what I will be sending to you. It doesn't take much space on an email. So what I would suggest is, I'm not sure, Tucker hopefully is on the line, if we can get your emails, or if you feel free to email me, I will type. I don't know that I can type the email to all of you, but feel free to email me if you want the slides. As far as the slides here, I hope that we will be able to send it to all of you guys as well. There was another question about the slides of the presentation. Okay, perfect. So Tucker just responded. I will be sending out the survey as well as the presentations of the day. Tucker, can you make sure that I answered all the questions in the chat? That's a very good question. I have another question here from Dr. Nathan. Do you still recommend screening high-risk children at 2 years of age or younger than 7 years of age? That's a brilliant question. If you look at the selective screening, we start at 2 years of age. But when you talk to the authors of the guidelines, they would say, you know, why bother the kids at 2? We can do it at 3. So if you have a child whose dad had a heart attack in his 20s from homozygous hypercholesterolemia, then of course you should do it much earlier. If you have a child like the one that I described where they have xanthomas, then of course you're going to check their cholesterol early on. But please don't do universal screening less than 9 years of age. You know, we get phone calls and emails from families of children that are 5 to 6 years of age where the profile was done as non-fasting and as part of the universal screening. And that's not what the guidelines would recommend. But if the child has diabetes, if the child has chronic kidney disease, if there is other risk factors, or if the mother has a hyperlipidemia and she's already receiving statin therapy, then yes, of course, you should be checking those kids early on to help guide the family and you know, teach them that they need to learn how to live a healthy lifestyle. Hopefully that answered your question. Okay, well, thank you guys so much for joining me today. Feel free to ask me any questions in the future. My email is a.harahsheh@childrensnational.org. A as in apple, H Henry, A apple, R rain, A apple, H Henry, S Sam, H Henry @childrensnational.org, and I'm sure Tucker can forward you my email as well. Thank you so much and have a great day. Ah, nice, thank you.